Good day, it's Ed Humbert. I'm an orthopedic surgeon that specializes in hip and knee replacement. We do this seminar more to educate patients on basic information about hip and knee replacement, what's new, what's upcoming, and what really patients should know, basic information about joints so they can be a little bit more comfortable before the procedure and after the procedure. The first question I usually get when I start doing these seminars is why listen to me, what makes me so special? So just to give my background, the first question I usually get is, I'm 6'1", I'm 180 pounds. That's the first thing to get out of the way. My background before I became a physician was I was a mechanical engineer. I went to the University of Florida, got a mechanical engineering degree. I went there, I subsequently took a job at a company called Schlumberger in oil, did some oil drilling for a short time. From that job I went to a company called Boeing for a short period of time as well. That's when I got an opportunity to go to graduate school in biomedical engineering at the University of Akron. At that point is where I got interested in implant design and making parts, and it seemed like it was a little bit more fun to put the parts in than to design the parts, and that's where I switched over to go to medical school and subsequently an orthopedic surgery residency. After residency, there's an opportunity to go work as an orthopedic surgeon and do general orthopedics or specialize in one particular fellowship area. That's where I went and did some work in specifically hip and knee replacement at a place called Joint Implant Surgeons of Columbus, Ohio. And that's where you do a high volume of one particular surgery, where you get very attuned at doing that one particular surgery over and over. That was specifically hip and knee replacement. Since that time, I've been in the Fort Myers area since 2003. Currently do about 1,000 knee and hip replacements myself per year. We just get very good at doing one particular thing. And that's just not myself, but that's my whole team with my PAs, my scrub techs, the hospital nurses, the circulating nurses, the anesthesia team, all do these same volumes with me, and they become very, very good at one particular thing. Our office is in Fort Myers. We're off of College Parkway, right between our two hospitals, which is Gulf Coast Hospital and Lee Memorial Hospital. We now have a Performance Health Surgery Center, which specializes in hip and complex hip and knee surgery as well as spine surgery, which was designed specifically for orthopedics. The facility you have your surgery done is as well important that they need to be doing a high volume of that particular surgery to optimize your outcomes. The more that facility does as well, the better your outcomes will be. So again, volume is extremely important in who you choose as a surgeon. There's been many articles published through the Journal of Arthroplasty that the higher number volume that the surgeon does, the better outcomes and reduced complications you can have. So the more the surgeon does and the more the hospital does will improve your outcomes and again, significantly reduce your risk of complications after the surgery. In Florida through the Agency of Healthcare Administration in the past has published volumes for hip and knee replacement. 10 years ago, they used to publish every single joint replacement where they were all done as an inpatient. Over the last several years, they've switched where they've removed the outpatient numbers and just kept the inpatient volume. Joint replacement now is becoming an outpatient procedure. So to look up the Agency for Healthcare Administration now, those numbers are not as accurate because most of our joints now are done as an outpatient. When you look at those numbers through the Agency of Healthcare Administration over the last 10 years, if you look at rankings and who does the most surgeries, there's probably 2,000 orthopedic surgeons in the state of Florida, and I've been in the top 5 as far as numbers goes for total knee replacement and total hip replacement consistently over the last 10 years. Just to go over basic information on arthritis now, typically patients come to our office and they don't ask me to replace their knee or hip. Their first question is, how can you help my pain, my swelling, my stiffness of my hip or my knee? So typically arthritis can cause pain, swelling and stiffness. Hip as well can cause groin pain, thigh pain and leg pain. The personality of the patient seems to change. So the wife usually says, my husband's grouchier than he usually is. He's not sleeping. He can't go as long as he used to. And that's what triggers them to come to our office. This is a slide of just a normal natural knee. The natural knee is composed of bone. The articular cartilage, which is on the femoral side, the tibial side, and the patella, is a smooth frictionless surface for your joint. Articular cartilage, which is what the surface on your joints are made of, has a coefficient of friction of about 7 times less than ice on ice. So it's probably the smoothest surface on the planet if you put those surfaces together. So our x-rays in the office showed significant changes in the joint space between the femur and the tibia on the knee and the femur and the acetabular on the hip. As the joint space becomes narrowed, we can easily see on these pictures that the cartilage is worn to bone. When the bone becomes exposed in an arthritic joint, the bone sees high stresses. That high stress can develop extra bone, which are called osteophytes. So as the osteophytes are getting bigger, your knee's getting stiffer or your hip's getting stiffer, and the pain becomes more severe. The hip joint is a ball and a socket, same articular cartilage, so that same smooth frictionless surface that's on the knee is on the hip and every other body part. The acetabulum of the hip and the femoral head of the hip also has that nice smooth cartilage. As that surface wears, that articular surface, we can see on the x-rays that joint space narrows. As that joint space narrows on our x-rays, we notice that the joint can significantly progress to bone on bone. This is just slides that are showing that progressive wear of the cartilage. In this last slide, we see osteophytes forming. We see bone exposed on the femur and the acetabulum. That will cause significant pain, stiffness, and swelling of your hip or your knee. And this is the last slide that basically shows severe osteoarthritis of a hip joint. Once we see that we've examined you as a patient, we know what your complaints are, we've seen your x-rays, we realize you have arthritis, the next step is to decide what do we do with your hip or knee at that point. Generally, we recommend there's nothing better than your own natural knee or your own hip. If we can continue to keep your own hip or knee with conservative care, we would recommend that forever. Conservative care is anti-inflammatory medications, pain medications, we can try injections of the joint. All can be helpful to keep your own parts. If you can keep your own knee or hip, there's nothing better than your own natural knee or hip. The last resort would be surgical. This next slide shows just more pharmaceutical or medication-wise. We can try pain medicines, which is your Tylenols, over-the-counter medicine, which is ibuprofen, which is your Advil or Motrin, can be very helpful. A real common medication patients are using is glucosamine chondroitin. That's not been shown to prove to work for arthritis in any way at all, but many patients that take it seem like it helps them, and there really are no side effects to that. So if you're taking it and it's helpful, we don't mind you continuing your glucosamine, although there's no proof that it works and it can become very expensive. The other things we can try in our office are injections, so we can actually put the medications where you need it. Injections specifically would be a corticosteroid type medicine, which is an anti-inflammatory that we can put directly into the knee or the hip, can give you significant improvement in pain, relieve your swelling, and relieve the fluid in the joint line and dramatically improve how your knee or hip feels. If you can get away with simple injections and keep your own parts, we would do that forever. Hyaluronic acid is another medicine that we'll try for knee joints. Medicare has approved that, where it's a series of injections or a one-time injection of a lubricant of the knee. The lubricant is just basically a high viscosity fluid that helps lubricate the two surfaces of the joint. At that point, if those two work and you can keep your own parts, we would recommend doing that forever. The alternative injections, which I'm not a huge fan of because they're very, very expensive and they haven't been proven, are stem cells and platelet-rich plasma. So stem cells are something that anyone can get. Anyone can put them in your knee. They're being used by many different medical offices, from primary care to chiropractors to just business people, trying to prey on people that need joint replacements. Again, there's zero proof that stem cells work for knee or hip arthritis. These injections can cost anywhere from $500 to $10,000, and they're not proven. So it's not something I would want to hang my hat on. If someone has the ability to pay for them or the resources, we would say if you're willing to do them, we're happy to do them, but we don't usually push those types of medicines. Good old ibuprofen or Motrin or Advil is great. If you can take those 2 to 3 times a day and feel great, we recommend doing that if you can. The prescription medicines of anti-inflammatories will typically prescribe are Celebrex or meloxicam, which are two that are just a little bit safer. The anti-inflammatories all have a risk of bleeding. Celebrex and Mobic have reduced that risk of bleeding intestinally. The other risk that all anti-inflammatories have are they're excreted from your kidneys, so they can cause some kidney failure. So we recommend, if you're on high doses of that, to be checked by your primary care physician for bleeding or kidney function, which should be doing probably every 6 months to a year. The lubricating injections, which there's many different versions and companies that make them, again, if they can help and you can do them every 6 months, they're great. But again, some patients will do them and see they don't help at all. Some patients do them and feel like they're a wonderful help. The corticosteroid injections, which we can do every 3 or 4 months, if they're needed, can be also very helpful. Platelet-rich plasma, again, is one of those alternative injections that we can try. We basically will take your own blood, spin the platelets down, and inject the platelets into the joint. You're basically giving us the product, and then not our office, but some offices out there are charging thousands of dollars to inject these platelets back into your own joint. So you're basically giving them the product, and they're charging you for it. Again, they're not proven. They haven't been shown to help arthritis in any joint at this point. And I think they're more of a placebo type medicine, but there are patients that are requiring or asking about it. And that's kind of my opinion on on PRP or platelet-rich plasma. Other simple things patients we recommend before they start deciding to go replace their knee or hip, weight loss can be a huge help on anyone's hip or knee. The joint forces that cross the knee and the hip can go to 7 to 8 or 9 times your body weight. So a 100-pound person may have 900 to 1,000 pounds across their joint forces. So a little bit of weight loss, if you can lose 50 or 100 pounds in these large people, can be a huge benefit, where I've had patients lose a significant amount of weight and then their joint does not need to be replaced anymore. They continue to do conservative care. People use canes and walkers. They can try all things they can do before they will replace their knee. Very commonly I get asked, what should I do before the surgery as far as activity? We always recommend to continue any activity that you can tolerate, whether it's lower impact biking, elliptical machine, rowing, walking in the pool, to keep your joint strong and as flexible as you can, keeping your own parts. Once we've tried conservative care, which are medications, injections, you've tried weight loss, you've tried your cane, nothing seems to work, is when you have pain that's so bad that you can't tolerate that joint. And as a patient, you're the one that tells us how much pain you're having. We can never tell you how much your knee or hip hurts. Once you get to the point where you've tried conservative and that's not helpful, and you're to the point where you think about replacing the joint, just remember, we're still replacing a knee or hip with metal and plastic. It's still a mechanical part. It's not your original joint. And we still always would tell you that keeping your own joint is still the best knee or hip you'll ever have, if you can get that one to not hurt. But when you get to the point where nothing helps, is when we can help you feel better, get rid of that pain, get rid of the swelling, and get you back to your normal activities. The options we have for hips and knees are arthroscopy, which continues to keep your own hip or knee but makes it the best it can be, or some type of replacement. Hip is basically doing a total hip replacement. Knees, there is an option of partial knee replacement versus total knee replacement. Arthroscopy is a surgery that does not replace the joint. The arthroscopy for the knee or the hip can remove tears of tissue. Specifically in the knee would be meniscal tears, and the hip could be a labral tear. Arthroscopy does not work very well for arthritis. So someone that gets a knee arthroscopy for a knee or hip that's severely arthritic generally does not do very well. They continue to hurt and they wonder what that surgery did. So you have to be very careful on who we select to do an arthroscopy. Typically it works best with meniscal tears or labral tears of the hip. Arthroscopy, again, is a great successful procedure for these meniscal tears. It's an outpatient procedure. People are back walking that very next day. They can get back to doing their typical daily activities within a week or two. And this is just a picture of Tim. He was a patient, we did both of his knee replacements. He's a farmer out in LaBelle. Tim's about 450 pounds, so we're just about to replace this horse's hips. The goal, again, of replacing your joint, remember, this is a permanent surgery. It's metal plastic in your knee or your hip. We're doing this, trying to do this one time and make it perfect. The best time to do well is doing it correctly the first time. But again, our goal is to do this safely through the smallest incisions we can make to do the surgery perfectly. That's the goal when I'm replacing your hip, is to not worry about getting out to dinner Friday night, but you going out to dinner 30 or 40 years from now, making sure you're safe and you're doing well. When someone decides to replace their hip or knee, again, I can certainly tell someone that they have severe arthritis and that they have something in their knee that we know what it is and how to fix it. When they decide to do that is based on their pain and how much disability they have on a daily basis. I can tell them I know how to fix this knee or hip. When they decide to do this is based on their symptoms and their pain. The two types of knees are total knee replacements, which is resurfacing the whole joint, versus partial knee replacements. Partial knees just replace part of the joint. Very few people are true candidates for partial knees, but there are some out there. Partial knees replace either the medial compartment or the lateral compartment of the knee. Again, can be very specific indications where if someone has isolated arthritis in one particular area of the knee, we can see in some of these x-rays that the medial compartment was worn on arthroscopy, and that patient had isolated pain to the medial joint line. That's someone who would be a great candidate to do a partial knee, which maintains your ACL, your PCL, which are the ligaments inside the knee, and feels more like a natural knee after that surgery relative to a total knee. Yeah, partial knees, again, partial knees have an advantage that it's a smaller surgery, so people typically get back to their activities a little bit sooner. Typically it's one night in the hospital or outpatient at this point, where most of them are done as an outpatient. They're off for their walkers and canes within 1 to 2 weeks. Partial knees generally keep the good parts of their knee. They keep their anterior cruciate ligament and their posterior cruciate ligament, and generally feel more like a natural knee to me when I examine them in the office, which hopefully correlates to the patient feeling like it's more of a natural knee to them. This is just video of someone who's a few hours after their partial knee replacement. As you can see, they're not running up and down the hall. They still had a knee replacement. So a partial knee is still a knee replacement, but typically their outcomes and their recoveries are a little quicker than a total knee. Robots with partial knee replacement or even total knee replacements in these days are out there. Robots again, have shown no long-term benefits at all. So a good robot result now is basically the equivalent of a standard knee. The robots also bring in a robot into the room. They bring in extra cost. They bring in extra people. The number of people in the operating room is directly correlative to the amount of bacteria in the room. So I believe that extra people bring extra problems to a joint replacement. Robots are also very expensive and have yet to prove a higher quality of the joint replacement or better outcomes at all. So they're basically adding cost and time to the surgery. So you're basically getting the same quality with an additional cost. So at this point, we've used robots if needed in the past, but we're not certainly sold on them at this point. Robotic partial knee replacements or total knee replacements typically can take 4 to 5 times longer than a standard total knee replacement. In our practice, partial and total knees with tourniquet times can take 15 to 25 minutes. Partial knee replacements or total knee replacements done with robots, we've seen in our area take 3 to 4 hours long. So they're significant longer with no benefits and outcomes, no reduction of revisions in the future, and basically additional cost. Recovering from, again, partial or total knee replacements, our goal, remember when we're putting your parts in there, is to try to give you less pain. We try to make the incisions as small as they can to do the surgery safely, but at the same time putting your parts in perfectly. All that said, we're trying to get you back sooner and quicker than we've had before. Because we're cutting less tissue, because we're minimizing trauma, we're trying to reduce blood loss, reduce muscle problems, and we're certainly seeing results where patients are getting back to their active activities much sooner than they were even 10 years ago. How do we do minimally invasive surgery with the same, minimally invasive surgery, with minimal incisions, but trying to get your outcomes as good and putting the parts in perfectly comes down to the instrumentation we're using. This is just an instrument that I used in the past where we had to fit the whole instrument into the knee joint to make bony cuts in the knee. This instrument on our left is a big bulky instrument that would take up 3 or 4 inches of the incision. Now that instrument is very small where we have to make a minimal incision into the quadriceps tendon. That quadriceps tendon during a knee replacement is where most of your pain will come. We typically have to cut up into the quad tendon with our older instrumentation. The newer instrumentation, you can see we can stop that incision right where the patella quadriceps tendon attaches and reduce your pain post-operatively. This is just a typical incision of a previous incision we used to make, and now we basically stop our incision right at the top of the kneecap. This is probably the first time I used our smaller instrumentation, which was many years ago. We still realize we still have to make the incisions the appropriate size to do the surgery safely, but now we basically realize if we can minimize the trauma, we maximize the outcome and the efficiency of patients doing well afterwards. Now here's a typical post-op incision, which is about a 3.5 or 4 inch incision. And here's an X-ray of that same patient with staple marks that basically go up to the top of the patella, which basically just shows we've cut very little of the quadriceps tendon after this knee replacement, which helps that patient move a little bit quicker. Assuming we've put the parts in safely and correctly, that patient will do very well for a long time. Here's just a video of a post-op day 1 surgery where we used to never see an active patient extending their knee and flexing their knee immediately. Now that's almost every single patient within the first a few hours of the first day of surgery. This was the woman that she was a Mayo Clinic nurse that she worked on the orthopedic floor for 40 years. She was probably the grouchiest person we met, and we thought if we can make her happy, we can make anyone happy. So again, incision size does not necessarily correlate to how well you do. We try to minimize the incision and maximize your results, but we still need to put the parts in safely. This is just an example of a patient that I did on the left with a small 3.5 or 4 inch incision, which got out of the hospital that day and was back to doing their activities within 3 or 4 weeks. My partner did her other knee with an incision that was probably 2 feet long, that she loves that knee, but that was 40 years ago and she still loves that knee. So the size of the incision doesn't necessarily correlate to what was done underneath. As long as you put the parts in correctly and safely, you're going to do well. This is just a little model of what we do with the knee replacement. We're not removing your whole joint. We're basically resurfacing the end of the bone. So we're removing a small amount of bone from the end of the femur and tibia. Once that bone's removed, We have implants that will resurface the end of the femur and tibia. Today's knees and hips are so well sized and so well, designed that we have a size for every single body type. So if you're tiny or small, there's every size in between. There's no need to make a custom knee these days based on the sizing we have. It's kind of like buying your shoes. There's size from size 1 to 25. There's no size we can't fit with a perfect custom knee today. These implants are just resurfacing the end of the bone, so we cap the femur and we cap the tibia. This is just an example of a knee that has a normal knee with a knee that has arthritis. A whole knee replacement, where we're replacing the whole knee, will resurface every part of that knee joint. So every part that articulates with the femur, the tibia, and the patella are resurfaced with metal and plastic. And this is just an x-ray of 2 bad knees and 2 knees that were done at the same time. Replacing 2 knees together at this point, they have been shown that 2 knees together, there's a very, very minimal benefit of recovering at the same time. But the risks of anesthesia and doing 2 knees together now, we've shown that there's a little bit higher incidence of medical complications, specifically with pulmonary embolisms, strokes, heart attacks. If someone wants to get a blood clot or a pulmonary embolism, we think there's a little higher risk of doing them on the same day versus staging them. So even comparing 1 knee to 2 knees, we're comparing 2 to 2, but just staging the surgeries. Specifically females have asked that there is a knee replacement made specifically for females. We've realized that over the years that female knee replacement comes in a pink box. Once we take it out of the box, it's the same as any other knee. So I get asked by the females a lot about, do I use that knee? And again, it's just a company marketing tool to try to force people to have that knee. It's not necessarily a better knee. They did narrow the size of the femoral component so that the parts did not overhang the bone, which can impinge on some soft tissue. But today's knees, whether they're female or not female, are so well sized. We have femoral components and tibial components, from size 1 to 25 now that can fit every body part. So there's no need for a specific gender or female knee anymore. Again, computer navigation or robotic knee replacement, again, is very valuable in certain patients that have had previous surgeries, that have had traumas where they've had implants with rods and plates and screws that we sometimes now don't have to remove those if we can use this navigation technology or robotic technology. We definitely don't have to use it in every single patient because it does increase cost of the surgery and the outcomes are no better. So unless it's absolutely needed, that's the time I'll use it. But generally we're still using our standard instrumentation and we'll compare it to any robotic or navigated knee with our standard instruments. Again, I talked about custom knee replacements. There are companies out there that will make a custom knee for each patient. That's not needed. It's like making a custom shoe. You would never order a custom shoe off of Amazon and get it. Right now we have sizes that intraoperatively we can size each component to the perfect size and we have them all available. So custom knees are really probably my least favorite knee out there as far as companies go. This is just Charles, he's fishing, so he was happy after both of his total knees. Now we'll get into total hip replacements. Total hips are again something that we're replacing the surface of the femoral head and the acetabulum. So this is a total hip replacement. So a hip is made of the acetabulum and the femur. So the pelvis of your hip has a nice smooth frictionless surface as well with articular cartilage. That's one side of your hip. The other side is the femur, which also specifically the femoral head has that same smooth frictionless surface of the articular cartilage on the ball. So that ball and socket is a nice smooth joint. When that surface wears down, that's the surface we replace. So when we replace your hip, we remove that femoral head and place a stem. So this is an example of the stem in the femoral canal. The other side of your hip replacement is the acetabular component, which is a titanium socket, which again, a plastic liner can be inserted in that. So this particular hip will be a metal on plastic hip. The things that you may hear about with hips and knees, with hips specifically, are what is your hip made of? The majority of hips are all titanium stems and titanium cups, but the surface bearing, which is the ball and the socket, can be made of metal or ceramic. The acetabular component, the plastic liner, can be plastic or ceramic as well. So a metal on plastic hip today is the best hip out there that can probably last 30 years. There's very low risks of that surgery, and that metal ball is basically indestructible. There are patients that may want that hip to last a little bit longer. That's when we get involved with using ceramic heads. So the ceramic femoral head is a much smoother surface under the microscope. If you look at a metal ball versus a ceramic ball, that ceramic ball still looks like a perfectly smooth surface even under the microscope. So that technically won't wear out the plastic liner as quickly. That's where if someone gets younger, where the patients are under 65, very active, and we may need to use a better surface bearing to last that person longer will be the times we switch to a ceramic part. There's risks of the ceramic, and that's why we don't use them in everybody. Ceramic is basically a glass material. It's brittle. It can crack and break. If that were to break in your hip, it's basically glass in your hip and would basically ruin the next hip after that, and it can be catastrophic. That's a very low risk problem. I've personally never seen one of my ceramic hips break or crack or have issues. I've tried to break them. I've tried to break them with vices. I've never been able to break a ceramic head. The other type of hips that are out there that you may hear about are ceramic hips that are also on a ceramic liner. So ceramic on ceramic hips are basically have an infantile wear rate. They almost never wear. So it seems like that would be the best hip to put in anyone. Again, like I said, there's risks of that ceramic that are very brittle. They're glass. They can break. They can also develop a very high-pitched squeaking sound. So if you go on YouTube today and Google squeaking hips, you can find hundreds of videos of patients that just walk and can squeak louder than anything you've ever heard. Those are typically ceramic on ceramic hips, and those can be a problem. And that's probably the one in my residency, the one few lawsuits I was involved with. That wasn't my patient, but it was a wife that would squeak at night, and it would ruin the moment, and they had to get that hip revised to a metal on plastic hip. So just because it's more expensive, which the ceramics are, doesn't necessarily make it better for you. So if you're 90 years old, your best hip is a metal on plastic hip. If you're 22 years old, that's when we start to talk about ceramics on plastics, and then everyone's individual. So we'll go over that with every patient beforehand. Again, the ceramic heads are pink, so these aren't female hips, but the ceramic material is a pink-looking material. The metal balls are the silver. There was a previous hip that was made of all metal, so the metal head and the liner were metal on metal. Those were actually wonderful hips that were developed in the early 2000s. We were putting these in for a short period up until about 2010, and we realized these metal on metal hips would release an ion, specifically molybdenum and chromium particles, that certain patients would have an allergic response to this, where their body would try to remove these small metal particles, which are billions of microscopic particles, and very aggressively loosen that hip joint. So these have kind of gone away, where the metal on metal hips were very, very good, but that small reaction has basically removed them from the orthopedic market, so we're no longer replacing hips with all metal surfaces. This is basically a worn out hip and a hip with a person that shows the femoral component and the acetabular component, which is basically what the hip replacement's made of. The hip replacements themselves are typically porous coated, so they have a porous plasma spray on the femoral component and the acetabulum, where microscopically the bone will grow into that implant and become really a permanent part of your body. This is an acetabular component, which again is a titanium shell with a porous plasma spray, which your body will grow into the back of this implant, and that's the acetabular side of your hip. This white thing is this plastic liner that locks itself into that liner and becomes your new bearing surface. Here's just some x-rays of an arthritic hip with a subsequent x-ray of the post-op day 1 and then 6 years later, and that's what you want to see. You want to see no changes on your x-rays over a long period of time. How do we do hip replacements? Again, the more common thing that people are asking us about is what approach we use, not necessarily what implant we use, but how do we get into a hip? There's many approaches to the hip joint. Specifically, in my residency, we did a posterior approach. I did that for 5 years. It's a very good approach. It's a very easy way to teach a surgeon or another doctor how to do that surgery, and the patients do very, very well. I will tell you that during my residency program, my experience was we had 35 surgeons working doing posterior approaches. We had also a high risk or high probability of dislocation. So throughout my residency, I was reducing hips or putting hips back into the socket after they've been replaced. I thought this was part of hip replacements. We just did this and that was natural, and about 5 to 6% of hips would dislocate and we'd have to put them back in the emergency room and send them home. My fellowship, where I just did exclusively an anterior approach to the hip, was 0% dislocation. So during my teaching, without reading books and learning about approaches, the anterior approach to me showed me that I didn't want to go in the middle of the night and reduce someone's hip after they were out to dinner and their hip popped out. So, my experience was my residency was all posterior, high risk of dislocations. My whole fellowship was an anterior approach, 0 dislocations in that whole year, and we did a significantly higher volume than my residency. So that just showed me that the anterior approach seemed like the safer way to put in hip for the life of your hip. The reduction of dislocations was dramatic, and I've been in this town now for probably 18 years, and I've had no primary standard hip replacements dislocate in that time. We have had traumatic accidents and traumas that have caused those problems, but no primary hips. The anterior approach, basically there's versions of this where we come directly between intermuscular planes. So we become two muscles called the sartorius and tensor fasciolata. We can push those two muscles apart with our finger, and that exposes your hip capsule. The hip capsule is basically a baseball glove leather material that wraps 360 degrees around your hip joint. That's basically what's next to get into your hip joint. So the anterior approach can split that capsule. So I have a little bit of a modification of the direct anterior approach where we can remove the trochanteric bursa or repair any gluteus medius tendon tears, which are very common with elderly patients. But then we do split the capsule and repair that at the end of the surgery. I think that's the best way for the long term of your hip to give you the best optimal hip for the rest of your life. So this is just a little video of basically a standard hip where this is the left hip, someone's flat on their back with their feet to the left and their heads to the right. Basically this approach is splitting between two muscular planes. So we split between the sartorius and tensor fasciolata without cutting that muscle at all. Once we separate those two muscles apart, we get down to the hip capsule. The hip capsule is something that we can split and repair at the end of the surgery, or you can remove that whole capsule. I found with completely removing the capsule, that caused a little bit of anterior hip pain for a little bit longer, that at this point now we repair every capsule. So basically you go home with all your original parts except for your femoral head and your acetabulum. This is just an invisible hand removing that capsule. We talked about dislocations with hip replacement. Dislocations when the ball comes out of the socket. When we replace your hip, we have to dislocate the hip joint to put the parts in. So that's part of a surgery that's what this video is showing right now. We're dislocating the hip so that we can remove the femoral head, reshape the acetabulum for your implant and put those parts in there. So this video is again slowly going through dislocating the hip joint. So this is specifically at the point where we dislocate the hip. Once that hip is dislocated, we can remove the femoral head. Normally, when we're replacing hips, they don't look as good as this patient does on the video. They usually look like worn out mushroom heads. In a typical day, we can do 10 or 15 joint replacements, so we probably have 7 or 8 of these femoral heads hanging around by the end of the day, and we have a nice bowl of soup. So at this point now, we're removing the femoral head. So this is a saw that takes the ball out. So this is a very common place where people fracture their hips. If you have a broken hip, we basically skip this part and you've done the work for us. But now we're removing the ball from the acetabulum. This is the part where we remove that femoral head. So that's the part that you don't go home with. The two sides of your hip replacement specifically are the acetabulum and the femoral component. The first part of the surgery is reaming the acetabulum. Just like every other body part, we have every size available to fit every human. So small hips or big hips, we have specific reamers that show exactly the size of the acetabulum. Once we find that you're identical size or perfect size, we ream the acetabulum and place the implant. That's the exact size you need to be. That's the acetabulum part. The femoral component of the hip, we have broaches that size your own femur. So different sizes of people have different femoral components. We size from small to big. Once we find the appropriate size, we remove the trial parts, or we call them the practice parts, once we know that the part fits perfectly, and put in the permanent implant. So this is just an example of someone who's broaching the femoral stem. Once the broaching is done, we know the correct size, we put in the permanent implant. This hip at this point is still dislocated, so once this implant is permanently placed, we can reduce it. This is putting in the implant. Again, the ball that we put on your hip, whether it's a ceramic ball or a metal ball, is again based on discussions with us prior to the surgery, your age and how active you are. But again, this is the final part where we put on the final ball and reduce this hip. So the hip's currently dislocated, now we're going to reduce the hip joint. And hopefully that's the last time you'll see that hip ever dislocated again. Typical size of an incision, they can be as small as 3 inches, they can be as big as a foot long, depending on the size of the patient. But whatever size the patient is, we make sure that incision's as small as it can be to do the surgery safely first, and then worry about putting your parts in perfectly. Now this is just a video of someone who's a post-op day 1, right after her surgery. She's still not running up and down the hall. She just had a hip replacement. She'll be on her walker for that first probably, 2 to 3 weeks, and just progressing gradual every day. Here's another one that was trying to use her cane, her post-op day 1. We don't recommend canes initially, just because the risk of falls and trips becomes very high, that we'd rather you stay safe and not have any falls or trips. This is 4 weeks post-op after a hip replacement. I think only reason he was upset was because I was late for my appointment, but other than that, he was doing very well at 4 weeks without any cane or walker and back to pretty much doing most activities. Again, the goal of surgery is not really to get you out to dinner on Friday night after a Thursday surgery. We can make incisions as small as we can, and if there was a small incision contest on the planet, I could probably win it, but our goal is to not make the smallest incision at the expense of doing a poor job. So it's as small as it can be to do the surgery safely and perfectly. But by doing that now, because we're cutting less tissue, we're getting less blood loss, we're causing less swelling, we're causing less pain, the risk of blood transfusion now after a knee or hip replacement is basically down to probably less than 1%, assuming you come in with a normal hemoglobin level prior to that surgery. The goal of your joint replacement is to get rid of your pain, to get you back to doing the things you like to do without worrying about when that knee or hip's going to hurt. That's the main term goal. So the patients that impress me are the patients that have had their knees and hips, and they're at their 20 year and their 30 year and they're still doing perfectly. The person that has their hip or knee and is out golfing 3 days after their surgery does not impress me at all. It just shows me that they're not listening to our instructions and putting themselves at risk. Doing these surgeries, we do a lot of them, so the more we do, the less risk you have of problems. This is just an example of an article that we have in our orthopedic journals that showed a surgeon who learned how to do this anterior approach over a weekend course and then went and did it on Monday and put in a 38 size ball into a 28 size cup that didn't fit. So that's basically a surgery that had to be redone the very next day. So just because the incision's small doesn't mean what we did underneath is perfect. Another example of Dr. White up in the Chicago area looked at over 400 hips by surgeons that are not doing high volume surgery. So for instance, I probably do 120 joint replacements a month. We probably do 70 knees and 50 hips. Most surgeons might do 1 or 2 hips or 1 or 2 knees a month. So they're doing 20 or 30 a year, which we can do that in a week. Those surgeons, when they start to shrink incisions and do these new approaches, I think basically just put themselves at having higher complication rates. And that's what this article showed by Dr. White, that their complication rate went from 3% to 12% just by trying to make the incision small. That is not worth doing it, and that's not keeping the patient safe. Again, our standard incisions has shrunk over the last 18 years. We've done it very gradual and very slowly, where I think we could probably make the smallest incision on earth, but our goal is not to do that. But by doing that, we've reduced transfusion rates of blood. We've gotten patients moving their knee where they can actively extend and move their knee probably the same day of surgery after knee replacements. Our incision sizes, if we measured them 20 years ago, were 5 or 6 inches. Now they're probably 3 or 4 inches. So gradually we've reduced those incision sizes. That reduces our narcotics after surgery, so much less need for narcotic medications. Return to work, someone asked me, when can we go to work? Typically that's between the 3rd or 4th week, where 20 years ago we would tell them 3 months, and every time it was 3 months. There's zero difference in our risk of complications now. By reducing our incisions, we're getting people back a little bit sooner than we had before, and with no increased risk of infections or increased risk of any complications. This is just a Rob who's in this yellow jacket on a river. He goes up and down the New River. 8 weeks after his hip replacement, he was back to doing pretty high-level things where he'd go up and down this river 2 or 3 times a day. Complications, again, no one likes complications. We don't like them. The patients don't like them. We know they're out there. We try to prevent them. So I'd put my team against anyone on the planet as far as optimizing someone's potential risk of having reduced complications. But like I said, dislocation's a risk. During my residency, I'd see a significant number of dislocations with hip replacements. At this point now, that risk is basically down to about as close to 0 as you can get with the anterior approach. Infections, again, are a risk of any surgery. Hip and knee replacement are not immune to them. If someone did get an infection, that generally means they have a high comorbidity of getting those infections, like diabetes, smokers, and obesity. That can put you at a high risk of having that. But if you do have an infection, we certainly know how to solve that problem. It's just something you don't want to have to solve, but there is a risk of that. Blood clots after hip and knee surgery are common. We try to get you up and ambulating and walking as quickly as possible to reduce that risk. We give medications to prevent blood clots, which blood clots in general will cause swelling and pain in your leg. The blood clot itself can get so big it can break off and float to your lung and cause what's called a pulmonary embolism. That embolism can kill you, cause shortness of breath, and that's the big risk of a blood clot we're trying to prevent. Knees and hips can still hurt after the surgery. People that have recurrent pain, sometimes are treated conservatively. Sometimes there's something wrong with the part, or it's unstable, or has a problem that we need to redo. Leg lengths is another issue, specifically with hip replacements. If we wanted to make your leg longer, we could probably make it 1 or 2 inches longer than it was prior to surgery if we were trying to do that. Certainly patients don't like long legs, and we like to make sure that they're perfect. So after your surgery, I personally check you. Without me in the room, my physician assistant Tyler will check you before you wake up from that surgery. If we both don't agree you're perfect, the anesthesia won't wake you up. So that's something we're very keen on, that we make sure that you don't have any leg length issues prior to leaving. Nerve and vessels that we're working around are very close to your knee and your hip. Nerves specifically do not like any traction or pulling on. If we pull on a nerve without even cutting it, it can go to sleep. So that's caused a nerve palsy, and probably the most common nerve problem after a knee or hip is a foot drop, which can occur up to 3 to 6 months after the surgery. They typically get better. Fractures after surgery can happen. Stiffness after a knee or hip can occur, that we may have to continue with your therapy a little bit longer than we typically would. And again, eventually these are human parts. They're metal and plastic. They can wear, they can loosen, and hopefully they last you 30 or 40 years, but if they wear out, we can redo them, and that would be called a revision. There's also medical risks of any surgery: heart, lung, strokes, heart attacks. They're all risks that, again, are dependent on sometimes what the patient comes into surgery with. Our complication rates are probably directly proportional to the comorbidities that the patient comes to surgery with. So the more problems you have going into surgery, the higher risk you're going to have of having a problem. Again, all those complications said, it's been shown in many studies across the Journal of Bone and Joint Surgery, the New England Journal of Medicine, 50 different articles that show the more the surgeon does, the less problems he's going to have, or a reduced number of complications, and much better outcomes. So that's probably been shown many, many times in many articles. This is Caroline. She was waterproof after 6 weeks, after 2 hips, and was back to her scuba. Therapy goes, or hospital, we're in the hospital and we're in the surgery center. Typically patients now are probably 50% or more now are going home the same day of surgery, or a minimum staying 1 night in the hospital. Generally you're back to your walking with a cane or walker for that first 2 to 4 weeks, basically just to your pain tolerance. Physical therapy will be started probably immediately after surgery for that first 2 to 4 weeks. Incisions, if there are staples or incisions that we have to remove staples, we'll take them out about the 2-week mark, and we'll generally see patients back up at the 4 weeks time. Remember, initially after that surgery, we try to remind everyone that your leg will not do what you expect it to do, which puts you a little bit of risk of falls and trips that first 2 to 4 weeks. That's why it's most important to stay safe, use your walkers, use your canes, and don't try to overdo it. The patient that tries to do too much too soon generally gets more pain and has more problems. Foot pumps, where you're pushing down on the gas and pulling up on the foot, 5 or 6 of those after surgery every half hour really helps reduce the risk of blood clots after surgery. We generally will give you pain medicines and anti-inflammatories to help with your pain. And basically your goal is to just be safe. Just keep that in the back of your mind after any surgery, is just remind yourself you're at risk of falls and trips and avoid them. Our physical therapy team will set you up with the big people. We'll get Yop, the big guy, and the little one will get Laura, the little one. What can people do after surgery? Again, you're walking the same day of surgery, so people wonder how long are they going to be down for. You're walking with a walker the day of surgery. You're going to be using that walker for the first 2 to 4 weeks before people can start planning on driving. Getting back to going out to dinner and things like that is probably about the 4 to 5 week mark. If you're planning on golf trips or trips with your friends, I'd probably plan on 6 to 8 weeks before you plan on doing anything with travel. Again, this incision size, the size of your incision, again, is not as important to me as doing what's under that incision and making sure it's done correctly and safely, but we can try to minimize this incision as small as we can. This is just Nancy. She was running up and down this Peruvian condominium 6 months after both of her knees were replaced. So again, before you're with your cane, and afterwards you're with your golf club. Again, thanks again. This is Ed Humbert from Joint Implant Surgeons of Florida. We thank you for choosing the best surgeons in the joint.